Good morning. It's 9 a.m. and we are going to begin our webinar. Welcome AAPOS members and guests to the 7th Annual Kushner webinar. I'm Scott Larson, broadcasting from the University of Iowa. I currently serve as a member of the AAPOS Board of Directors, and I've been asked to serve as the moderator for our webinar today. This webinar is made possible by a collaboration between the Department of Ophthalmology and Visual Sciences at the University of Wisconsin and AAPOS. The Kushner webinar also serves as a tribute to Dr. Bert Kushner, now Emeritus Professor at the University of Wisconsin, and a way to celebrate all the advances he has brought to our field. Today's webinar will feature 3 speakers, followed by a short question and answer session featuring questions from the audience. We will then hear from our featured Kushner lecturer. After the Kushner lecture, we will be honored to hear a few words from Dr. Kushner himself. We hope you enjoy the program. Our first speaker will be Dr. Craig McEwen. Dr. McEwen is a professor of ophthalmology at the Bascom Palmer Eye Institute at the University of Miami, Miller School of Medicine. He will speak to us today on vessel-sparing strabismus procedures. And we will switch over to his slides now.
You're muted, Craig.
There we go. Are you seeing my slides yet?
Not yet.
Nope.
Let's try that again. Worked so well a few minutes ago. Let's try once more. How about now?
Not yet.
Scott, I'm not quite sure what I'm doing wrong here. Let's see. Did I leave? I'm still in Zoom. I can see you. Can you hear me okay?
Yes.
And I see my own slides. If it takes too long, we'll have somebody else go before me. But let's just try again.
Yeah, we can't see you or the
Let's
slide.
try it once more.
We'll
How about that?
and you have them on your PowerPoint. So if you open,
Oh yeah.
Oh, here we go. Yep.
Okay,
That's it.
perfect. Thank you.
And then
I'm so
just
sorry.
yeah, there you go.
Yeah. Good. Am I on and okay?
Everything's good.
Wonderful. Well, for our audience, it's a pleasure to be here and an honor to participate in this honor of Steve. And I wanted to thank Bert, Steve, Scott, and all the AAPOS membership. I noticed many good friends in the audience. So this will be fun. Let's see if it advances. I'm having a little advancement problem. There we go. I have no financial interest in the material being presented. Let's talk for a few minutes about anterior segment ischemia. It was first described by Schmidt way back in 1874, not related to surgery, but with occlusive vascular disorders. And it was about 80 years later that people began to recognize that it also occurred after surgery, part of which was our advancement in surgery, particularly retinal detachment. So in the 1950s, we had detachment and strabismus. So the signs of anterior segment ischemia usually occur promptly within about 24 hours. In this patient, we see corneal edema with folds. And this is one of our referral patients who had iris atrophy, segmental cataract, hypotony, and a few other issues. So an important question for those of us performing surgery is, what is the risk of developing anterior segment ischemia? And the answer actually depends upon how the question is asked. So if we look at a retrospective survey of our AAPOS members, 1 in 13,000 cases by recall. If you look at it a different way, 100% of the patients by Saunders and Phillips developed anterior segment ischemia. So the risk of this is somewhere between 1 in 13,000 and 100%, depending on what we're doing and many, many other variables. The risk factors for anterior segment ischemia include many things, which all of us are familiar with, but probably age and number of muscles receiving surgery are the most important. So this is a good case. And I don't see these kind of cases often more, but this was a 65-year-old with large angle esotropia from bilateral traumatic sixth nerve palsy who had previously had a recess resect procedure on the medial rectus muscle and lateral rectus of both eyes. So now he requires what I would call a powerful transposition. So this was our challenge. So occasionally, the ideal procedure from a mechanical perspective creates a significant risk for the development of anterior segment ischemia. So there are many, I think I have about 18 here, and I put some little blue circles by the ones that might spare the vessels. And then, of course, for Bert Kushner, here is something he described way back in 1979 related to a Jensen procedure modification. Let's look for a few minutes at anterior segment blood flow and anatomic considerations. This is a classic picture which was in black and white in the original from labor, but there is an interesting feature. Notice in my yellow arrow there that the anterior ciliary vessels are not on the tendon or in the tendon as shown in the diagram, but they're actually, we'll see in a few moments, on the tendon, as most all of us know. There's also a number of important papers relating to the classic 7 anterior ciliary vessels or arteries, which is actually not the case as shown in these 2 papers and others. So you can observe this in the clinic and the operating room. This is after a little bit of phenylephrine. We very nicely see the anterior ciliary vessels on the superior rectus and inferior rectus of this patient. Also, at the time of surgery, we began to look, and we noticed that the anterior ciliary vessels merged from the muscle posterior to the tendon. They then traveled on the surface of the muscle, following a somewhat serpentine course, which is advantageous if you're going to put them on stretch. The vessels often travel in little groups, as you can see here in several sets. And sometimes we'll see pulsation, which I may show you in the video in a moment. And they continue onto the scleral surface in front of the tendon, giving us maybe some surgical opportunities. And we observe the flow to vary in a few of the vessels, not the pulsatile ones, from anterior to posterior and posterior to anterior. So we looked in a very non-systematic way at a couple of pathology specimens, including cadavers and our own surgical specimens. And what we noticed is, yes, indeed, they are on the surface of the tendon. They're enveloped by connective tissue, which is continuous with the muscle capsule, and there are relatively few branch vessels over the tendon, which makes sense metabolically. And a potential dissection plane exists. So here's a diagram that we had made some years ago. And if we look at position 1 here, this is our histologic specimen showing the anterior ciliary vessels in the substance of the muscle. And here we're going a bit further forward. Now we're over the tendon, and here they are traveling on the surface of the tendon. And here's an example of a branch vessel. Again, relatively few overlying the tendon. What is interesting about this, it creates a potential dissection plane, as most of us know, that is over the tendon. And here's a group of at least 4 vessels. One looks arterial, the others may well be venous. So this is a diagram of sagittal section of a hypothetical muscle, showing again that the anterior ciliary vessels emerge from the substance of the muscle, travel on the tendon, and then onto the scleral surface, as shown by the yellow arrows. So let's look at some surgical techniques for dissecting and preserving these vessels during strabismus surgery. These are instruments. I personally feel strongly about using the microscope based on a number of experiences. So in my mind, the microscope is not equal to loops, and I do have some 4.5x wide field loops, but even that is not quite as good as a microscope. And this is from Monty Mills, and this was a patient who actually had not by them, but had attempted vessel dissection with a pretty significant anterior segment ischemia. So the technique is tedious, but easy to do. Our second-year residents have done it. Here we are not lifting the vessel directly, pulling on the connective tissue, and placement of the suture in the tendon after dissection of the anterior ciliary vessels is quite easy. Suture is here, and our proposed cut line is here. And here's, again, from our original article, a diagram of the vessels preserved. And here we've done recessions, resections, and transpositions. Now, I very rarely have done resections, transpositions by far and away the most common, and an occasional recession. And again, I've done very few of these recently because our surgery internationally has improved so much in terms of putting the patients at risk. So this is a diagram of a full tendon transposition, and this is a full tendon transposition diagram. And here's a superior rectus with the preserved vessels at the tip of my arrow, I think you can see. I'm going to show just a tiny little bit of this, but notice the pulsations of this vessel here. I would say about half the time we see that. And there are actually 4 groups of vessels that I will move forward. And I'll show just a little of the dissection. Again, don't grasp the vessel directly. We're spreading with some Reeshauber scissors at that time. I now use some of the borrowing things from the vitrectomy group, our retinal surgeons. And if we sneak forward a little bit, and this is probably not wise to use a suture as I was using at that time, but notice draped over the suture are 4 vessels, groups, I should say, some having more than 1 vessel. And then the suture is easy to pass. This is a S29 fairly thin wire needle. And of course, cutting it, you want to keep the blades. In this case, I think I'm using sharp Westcotts, get the blades behind the preserved vessels because we do lose them. And we also lose them at times on the abrupt snapback. So who's ever holding a hook needs to ease up just a little bit, which I always like to be me. So if I break them, it's my fault. And then we go just a little bit forward. There we are. Now I'm combing this. This is a peristaltic pump, basically. And there's 4 groups of vessels, and the needle pass is quite simple. So let's look at some important questions. How often do we destroy them at surgery inadvertently? That's pretty easy. This is a little more difficult. How often do they fail, but we think they're working and they fail later? That could be dangerous for our patients. And does this procedure really prevent anterior segment ischemia? So we think it's about 10%, at least in our little series. And you can see, though, on this particular group, there is a preserved one in green still working, and the other one is broken. But this is important. How often do they fail, but we don't know that? So this is one of my patients where we were doing fluorescein angiograms. The medial quadrant defect is actually natural preceding her surgery. It's part of her problem. But here's a vessel here that is not functioning that I thought we preserved, and here's several papers that address that. So again, I think it's about 10% in our group. So I believe that surgical technique is very important in high-risk situations, which is typically the only time I'll do it. And does this procedure really prevent ASI? So in an attempt to answer this, we looked at an animal model that Fishman, Repka, Green, Diana, and Guyton very cleverly did a number of years ago. And does it really present it? Well, their anterior segment ischemia wasn't as dramatic as ours because my very good clinical fellow, Bill Lavin, was able to obtain 4 elderly monkeys. We didn't know their exact age, but they were sitting next to, or living next to the monkeys that Joan Miller had up in Boston. And I could tell immediately, we could all tell that our monkeys were geezers and hers were quite youthful. Here's an example, not hers though. So this is our group. And I'll briefly go through these. This is a muscle. Here is the suture. Here are the preserved vessels. And we just did a very small recession on these cynomolgus monkeys. Well, does it work? When we set up the protocol, everyone before us had never seen very severe anterior segment ischemia. And the answer is yes, it does, at least if you're operating on cynomolgus monkeys. So here are 4 vessels without preservation, and here are 4 vessels with preservation. And the reason our anterior segment ischemia was so terrible, didn't need a slit lamp or fluorescein or any special studies, I believe was because these 4 monkeys were extremely old. So, and then there are other techniques. This is one described by Ken Wright. Here is an experimental, that was in monkeys. He's also done it in humans. And then recently there was a, well, not quite so recently, a rabbit study, which I've not seen the photos for, out of China. So we thought we were quite original. However, the very same year, Roth did the same thing. And then somebody mentioned Carlson and Jampolsky had actually done something way back in '79. I'll show you an extract that Federico Velez helped me find. And then there's this as well that came out from South America. So here underlined in this article is, so this is Jampolsky and Carlson stripping the vessels with a needle. And then here's Villacoro, but notice not only it's him, but I believe it must be his father. And down here we see references going back to 1921 and 27. So I hope this is helpful, and I wanted to thank you for your time and the invitation to participate in this honor for Steve. Thank you.
Thank you, Dr. McEwen. We are going to now move to our next speaker, who will be Dr. Stephen Kraft. Dr. Kraft is a professor in the Department of Ophthalmology and Visual Sciences at the University of Toronto, and he practices at the Toronto Sick Kids Hospital. He will speak to us today on lateral rectus resection for esotropic Duane syndrome.
Well, thank you so much for the introduction. Can you see my slides?
Perfectly.
Wonderful. It's a real pleasure to be involved in the Kushner webinar, and it's the second time I've had the pleasure of being on a panel for this. The first time was 5 years ago, and this medal I wear proudly, Bert. Something that you gave me at the end of that one. And to Steve Archer, congratulations on just another major stellar milestone in a terrific career. And when you get your medal later today, I hope that you'll be able to also wear it proudly. And it's a bit heavy, so I'm just going to remove it right now, but it's going to be sitting right beside me here throughout this webinar. So we're honoring Bert Kushner, and when I think back, I've known Bert for over 40 years now, and I call this annual webinar the Kushner Fest, because we're celebrating a wonderful friend and a terrific pediatric ophthalmologist who's one of the original and innovative thinkers in our specialty, and isn't afraid to challenge existing dogma. And Bert, as I wished you 5 years ago, I want to wish you nothing but good health so that you can continue to enrich us and join us on these webinars for many, many years to come. So I don't have any financial or conflict of interest disclosures, but as I always do at any presentation, I do declare a very strong clinical interest. This is a very common classification that's been used for many years from the studies of Huber. And I've been on a kind of a soapbox campaign for many decades now to try and get colleagues to stop using this convenient type 1, 2, and 3 classification, because it really oversimplifies what is a very complicated entity. Duane syndrome is an innervational disorder under the classification of the CCDDs, or congenital cranial disinformation disorders. And I wanted to refer you to a lesser quoted article from, unfortunately, late Alan Scott, whom we lost just last month, but from a study that goes back 50 years, where he and his group used to do EMGs of all of the ocular muscles at the same time. And you can see that in this example in one patient, where they recorded from all of the ocular rotatory muscles, that when a patient went from abduction to adduction, that the EMG showed activation of almost all of the third nerve innervated muscles. And this was predicted by studies that go back many years prior to that. This is an anatomic drawing from a group in Italy who many decades ago showed a case of an orbit that they dissected in a patient who had Duane syndrome in life. And you can see that the lateral rectus, as we know, has a 6th nerve that is either hypoplastic or malinnervated. And in its place, the third nerve, they showed already that you get innervation to both the third nerve innervated muscles as well as the lateral rectus. But that then brings us to the point that innervational disorders like this must have quite a spectrum of possibilities. And that's the key in analyzing Duane syndrome. So as just an introduction to the talk I'll be giving, we have to remember that Duane syndrome is a spectrum, and there is no single menu for surgery in these patients, and each case has to be individualized, although with the many innovative colleagues that we have around the world, there may be more than one plan that may actually work for a given patient. To bring everybody to the same understanding of the classification of duction deficits, just to show you here what I mean by these various numbers. It's used quite widespread, but -1 limitation means a slight limitation into the field, -2 about 50% limitation, -3 is significant limitation, -4 means cannot get into the field at all. And what I'd like to do is show this to you as how I analyze a case. And you have to first look at the spectrum of alignments, whether they're ortho, iso, or exo in primary position, the degree of retraction, spectrum from mild to severe, the up and down shoots on adduction from mild, moderate to severe, the abduction limitations by the classification I gave. It can be from the abduction can actually be full in some cases, all the way to significantly limited. Same with the adduction, can be full right to severe limited depending on the type. And we have to also analyze the field of binocular single vision. We want to preserve as much as we can and even expand it if we can. And those features are listed here, with the additional two that we also look at the compensatory head posture, that a good reason to intervene in a patient, and also whether it is unilateral or bilateral, although today I'm going to confine my comments to unilateral Duane syndrome. And as I mentioned, there's a large variety of possibilities in this syndrome, as our experienced colleagues will attest to. The most common form, and the one we're going to address today, is the type where a patient has a limitation of abduction and an esotropia in primary position, as shown in this patient with a left head turn. And you notice I did not say type 1 Duane, I said it's Duane's with esotropia and limited abduction. And over the last couple of decades, very innovative colleagues have come up with various innovative plans for this type of problem. For many years, tried and true unilateral medial rectus recessions have been advocated by many, but full tendon or half tendon vertical transpositions from colleagues such as Linda Daggy and Federico Velez and Kumar Senner have written about various types of transpositions that are being used. Also, people also suggest bilateral medial rectus recessions. And what I want to give you is just one more tool in the toolbox, and that is a recess and resect for certain subcategories of this type of Duane's. If you go back into the major textbooks from the late Gunther von Norden and Emilio Campos, again, another luminary whom unfortunately we have lost within the last few months. The last version of their textbook from 20 years ago has a statement that says the resection of the lateral rectus in Duane type 1 should be avoided because it may increase the retraction of the globe and compromise adduction. Now, I had the chance to discuss this with Dr. von Norden and presented the data that I'm going to present to you today. And he actually agreed that when they were discussing and putting this into the textbook, they were referring to the usual amounts of resection or plication, which is done for the same angle of a routine comitant esotropia, which in experience is probably somewhere between 5 and 8 millimeters. And he had mentioned to me that if they were to put out a 7th edition, that this paragraph would have been revised to consider the idea of a small resection of the lateral rectus. Unfortunately, there was never a 7th edition, and so the last edition never had this changed. But I want to also acknowledge another out-of-the-box thinker, and that is Jim Mims III, who is now retired and practiced in San Antonio, Texas. And he was the first that I knew of who actually published data on using a resection of the lateral rectus in esotropic Duanes. And when Yair Morad, our illustrious colleague from Tel Aviv, Israel, was a fellow with us, he put together a few cases of mine and Jim's, and we published this and showed that you can get quite good results by doing small resections. But notice that if the lateral rectus resection was more than 4 millimeters, that you did worsen the retraction signs, as Campos and Van Noorden had suggested. So the key is to do this surgery and do small resections of the lateral rectus, and you have to keep it under 4 millimeters. And I'm going to show you the results of a prospective study that I had done a number of years ago of 18 patients from the childhood to adult years, who all had this subcategory of esotropia in primary position with a head position and limited abduction. And all of these patients, in order to do this procedure, had to have the following criteria: an esotropia at least 25 prism diopters in primary, mild globe retraction, and I'll just define that again in a moment, clinically normal adduction or no worse than a very slight limitation on adduction. The abduction had to be at least minus 3.5 on a scale of 1 to 4, mild or no up or down shoots on adduction, and a positive forceduction on abduction at the time of surgery. And the sign of mild globe retraction, including the adduction, is to look at the lid fissure height, which I do in all my patients, from primary to adduction, with no more than 33% reduction in lid fissure height. The cases, when you look at this spectrum, had to have a moderate to large esotropia. The retraction had to be mild. The up and down shoots, again, had to be mild. The abduction had to be significant, at least minus 3.5 to 4. The adduction minimally, if not at all, limited. And finally, a fairly large field of binocular single vision within which to work. And based on the earlier paper, no medial rectus recession was recessed more than 5 millimeters, and the resections were no larger than 3.5, which is, again, to emphasize, is less than normally would be done for a resection in a regular esotropia, because these muscles are stiffer, they're aberrantly innervated, and the length tension curves are different from a normal muscle. These were the results of these 18 patients that I put together. You'll notice that all of the resections of the lateral were 3.5 or 3 millimeters. You'll also notice that the deviations were all between 25 and 30, and the recessions were no larger than 5 millimeters. Here are the results, with a pretty good result in primary position for all of these patients, with a follow-up between 10 months and 60 months. Now, this is new data that I haven't presented before, but I now have 2 patients in this group in whom the results actually regressed over subsequent months. So since I put this together, I've seen these 2 patients, and you can see that this procedure is not 100% foolproof, and there is some regression in some cases. And what did I do for them? Well, in these patients, the esotropias that recurred settled out at about 14 to 16 prism diopters, again with significant limitations of abduction. In one patient, I re-resected their lateral 3 millimeters with a good result and a slight improvement in their abduction. The other patient elected to continue with prism and did not go ahead for surgery. I've also been asked, and this is a couple of new pieces of data, I've also been asked, have I ever done a lateral rectus resection alone in a tight Duane with esotropia and limited abduction? And the answer is I've not done it as the primary procedure, but I have 2 patients in whom I had referred to me who had had previous medial rectus recessions, both again in the range of 14 to 16 prism diopters, and I did lateral rectus resections of 3.5, both with good results and improvement in their abduction, and these have been stable for at least 8 months post-op. This is a summary of the patients from that first series I showed you. You can see that the post-op results on average are exceptionally good. And you can see that the improvement in abduction averages 2 units on the scale of 1 to 4. And notice also that we did not compromise the adduction in these patients to any significant degree. We had one patient of the 18 who developed a small postoperative hypertropia, and I had one of those patients of the 18 in whom there was a preoperative hypertropia that we were able to solve by offset of both those muscles downward. This is just an example of course, one of my good cases, showing you in preoperative, a patient with a left ESO with a moderate esotropia, significant limitation of abduction, and following her procedure, she had a orthotropy in primary position and her abduction improved to -1. Just to show you that this is not a unique result in Toronto, Canada, my illustrious colleague, Andrea Molinari in Quito, Ecuador, was kind enough to share a case that she had done, and she sent me her slides and agreed to let me show these results. A patient with -4 abduction and esotropy of 35, and postoperative following the same protocol, 5 recession, 3.5 resection. This patient had an excellent result, primary position orthotropia, and improvement of abduction to -2. You can compare this procedure to the other procedures that have been described over the last number of years, including the vertical transposition with medial rectus recession, which is the SRT and MR recess, and also the procedure of transposition, full transposition with myopexy, which we've called the Foster procedure after Scott Foster's initiative. And you can see when you compare those procedures to this one, the recess and resect, as well as to the bilateral medial rectus recess, which has been advocated by some for many years, you can see that the results for all of these are quite good, and that you get these patients under 10 prism diopters in primary position with a pretty good consistency. You'll notice as far as the improvement in abduction, that the results are actually best with the recess resect compared to what's reported for these other procedures. And finally, the compromise of adduction is actually quite minimal with most of these procedures, except perhaps for the medial rectus recessions, but these other procedures are all comparable in terms of minimal effect on adduction. This is a photo of the Great Wall of China, and this is where it actually ends, which means I'm almost at the end, and I want to show you just a couple of summary slides to remember that Duane syndrome is a spectrum of disorders, of innervational and mechanical problems, and that there's no single menu, and each case has to have an individualized surgical plan. And again, you have to analyze by the alignment, by the retraction, by the severity of the up and down shoots, by the limitation of abduction and adduction, and the goal of trying to expand, if possible, the field of binocular single vision. So in summary, what are the advantages of a recess resect? Well, first of all, you can see you get a predictable correction of the esotropy and the head turn. You have almost no risk of creating a new vertical tropia. You can correct a coincident hyper with an offset of both muscles. There's minimal risk of creating new torsion. And you improve the abduction and can then expand the field of binocular single vision in almost all cases. And another thing that's very important, especially for our younger colleagues, is that there are a lot of these newer and more innovative and fancier procedures for correcting similar cases of Duane syndrome. But it's not a bad thing to consider doing a primary procedure that will let you have an opportunity to do second procedures that are of minimal risk. In other words, if you have an over or under correction with this type of procedure, it's very easy to get the second procedure done and to approach a reoperation, which may be much easier than with some of the more involved procedures like transpositions. So I would suggest if you're looking at cases of Duane's in this category, that you consider doing a recess and resect, and it'll be very effective. And if you have to do a second surgery, you can get yourself out of that predicament quite easily. So as the sun sets here, in the skyline of Toronto, I want to thank Steve Archer again for inviting me to give this talk. Steve, congratulations on your Kushner lectureship, and I'm going to put this back on for my rest of this webinar. I wear it very proudly. And to Bert, thank you again for everything you've done for our specialty, and may you have many more years of good health to enrich us for many more years to come. Thank you to all of you out in around the world, and it's been a pleasure to be part of this Kushner webinar for the second time. Have a good day, and we'll speak to you and hope to see you all in person very soon.
Thank you very much, Dr. Kraft. I will introduce our next speaker, who is Dr. Monte Del Monte. Dr. Del Monte is the Skillman Professor of Pediatric Ophthalmology at the University of Michigan Kellogg Eye Center. And we'll let him get his video and slides up. He will speak to us on inferior oblique anterolateral transposition to treat intorsion and torsional diplopia in thyroid eye disease.
Can you hear me?
Yes, loud and clear.
All right.
You may want to turn your video on, though.
It's not? Oh, it says, okay, now start my video. Okay. Is that working?
We're good.
Okay, good. Again, Scott, thank you for that introduction. I want to also thank Steve Archer and the program committee for inviting me, and congratulate Bert Kushner on his long, illustrious career. He's published on almost all the topics we're discussing today. So let's see if I can get the slides to advance. These are my financial disclosures, and none of these are relevant to the presentation today. I'm talking again about the treatment of torsion in thyroid eye disease. We all know that esotropia and hypertropia are by far the most common types of strabismus due to tight medial and inferior rectus muscles. But torsional problems are not uncommon, both intorsion and extorsion. And if you see severely affected patients, torsional diplopia is also quite common. We also have to remember that A-pattern exotropia and down gaze is another common motility problem in these patients that makes treatment of the torsion more difficult. The goal of this presentation is to present a novel inferior oblique procedure to correct moderate to large degrees of intorsion in thyroid eye disease. And I'm going to start off with this case presentation. This was a 48-year-old woman who presented to another pediatric ophthalmologist not too far from me with oblique diplopia for 2 years. She had thyroid eye disease for 3 years. She had had bilateral orbital decompression for a compressive optic neuropathy 1 year previously. She was wearing glasses with a small amount of ground-in base-out prism from her optometrist. Her vision was slightly reduced in both eyes from the ischemia, normal refraction. And on exam initially in his office, she had the typical symptoms for thyroid eye disease strabismus. She had a large angle esotropia in primary gaze, less so at near. She had a significant right hypotropia. And she had, again, the very typical elevation and abduction deficiency that we see from the tight medial and lateral rectus. In the office, she was able to fuse with prism base out and base out prism over the right eye. So she had fusional ability still. Here are her diagnostic gazes, again, very typical with the A pattern already present between up gaze and down gaze. And on double Mannix rod at that initial visit, she had 4 degrees of intorsion, which is significant, as we'll discuss. Most patients with Graves' eye disease, because of the tight inferior rectus, will have significant extorsion on initial presentation. But again, this was small enough that she was able to sensorially fuse that with prisms over the eye. So the initial impression was thyroid eye disease, typical restrictive strabismus, following orbital decompressions, tight right inferior rectus more than left, and tight right medial rectus more than left as well. She had the A pattern, and she had been stable for 4 to 5 months by history. So he performed a bilateral medial rectus recession, as noted here, adjustable suture on the right eye. Not huge numbers. He put it back 8 millimeters, and he pulled it up actually 4 millimeters adjustment, a 6 millimeter recession on the left eye. He did upshifts of both for the A pattern, both of the horizontal, both of the medial rectus muscles. And he also did bilateral inferior rectus recessions, again, adjustable on the right eye, and again, not that large in size. However, postoperatively, she did not have a good result. She continued to have diplopia with severe torsion now. And she basically covered or closed the right eye constantly. So he referred her after a year for our evaluation. And she was overcorrected horizontally, as we see here. She had a pretty good result in terms of the vertical deviation, but she had 3+ intorsion on her fundus exam and 25 degrees of intorsion on double Maddox rod test. She was able to superimpose images with the appropriate objective deviation in prisms over her eye, but she could not fuse because of the torsion. And so here we see her, again, a small overcorrection horizontally, a little bit of a correction vertically as well. So now we have to decide what to do next. So I took her to the operating room. Forceductions were not terribly impressive, and decided to advance the left medial rectus on adjustable suture to correct her exotropia. And assuming that the superior oblique would be the best way to treat her intorsion, I did a complete right superior oblique nasal tenotomy. I used the Guyton exaggerated forceduction test to confirm that the tenotomy was complete. And after surgery, she still had diplopia with reading, and her torsion was a little better, but she was still bothered mostly by the torsion. And here you can see her measurements again. Adduction diversions again were pretty good. But on double Maddox rod testing, she had 22 degrees of continuing intorsion. So then the question is what to do next. Some people would have maybe done the superior oblique tenotomy on the other eye, although some work by Garrity had suggested a second superior oblique tenotomy was not particularly helpful. So I took her back to the operating room. Forceductions again were not terribly impressive, and we could passively extort both eyes, so suggesting it was not a firm mechanical restriction. So I decided to try a novel inferior oblique procedure to correct her symptomatic intorsion. I did bilateral anterolateral advancement of the inferior oblique to a point 8 millimeters posterior to the superior border of the lateral rectus muscle, which I initially called a bilateral inferior oblique heratoido, but now just call an anterolateral advancement of the inferior oblique. And these pictures drawn by Steve Archer on the Orbis program now illustrates a very simple procedure, what we did. And you can see this is a lateral view, temporal view from the left eye. Here's the normal inferior oblique position posterior to the equator, just at the bottom edge or a little below the bottom edge of the lateral rectus. And we transposed it under the lateral rectus to the superior border, what's called Feld's point, 8 millimeters posterior to the insertion, superior border of the insertion of the lateral rectus. And here it is at a sort of an intratemporal view. So again, a fairly simple procedure to do. This is done through 2 fornix incisions, intratemporal and supratemporal, so we don't compromise the limbal circulation, which relevant to Craig's initial talk, I think is also very important in preventing anterior segment ischemia, especially if additional surgery needs to be done. And here you can see the surgeon's view. This is the left eye before and after the procedure, and you can see how you were able to intort this left eye very significantly by this procedure. It's a very powerful procedure. So 2 months post-op, she was better, but she still had some diplopia with reading, and she still can't fuse with a prism. Again, her horizontal and vertical alignments were very reasonable. We could certainly put prisms up for that, but she still couldn't fuse because she had 9 degrees of intorsion on double Maddox rod testing. We tried initially separate readers with 8 Basin Fresnel prism in the right eye, but she couldn't fuse because of her torsion. So we brought her back to the operating room, and I resected the advanced inferior oblique muscle. So I basically found that new insertion at the superior border of the lateral rectus. I very easily could find it, identify it, resected 6 millimeters to make it tighter and put it on adjustable suture. And here she was ecstatic, no more diplopia, very small exophorias at distance and near, and 2 degrees of extorsion, easily fused. So again, in her case, persistent paid off. Now, intorsion and thyroid eye disease has been described previously by a number of authors here. The largest study was by Garrity in 1992. We had 21 patients, all who had had orbital decompressions and bilateral medial rectus recessions and bilateral inferior rectus recessions. Again, very typical pattern for these patients at that time. He did superior oblique tenotomy, found a mean decrease of about 7 degrees in torsion, and also a small improvement in the exotropia in down gaze, because these patients almost always have that A pattern, XT and down gaze. And there was essentially no improvement when he did a bilateral superior oblique tenotomy as well, so not much difference there. He also recommended some horizontal and vertical transpositions of the rectus muscles to correct the residual deviation. I looked at my initial series for my SCOBY lecture in 2001, and I found that 9% of 135 patients that we had operated on in this sort of context with the decompressions and inferior, well, in those days I was doing bilateral inferior rectus recessions and bilateral medial rectus recessions, had symptomatic intorsion. And they could not fuse with a prism, and they were extremely unhappy. They weren't able to read or use their eyes. Again, often followed by lateral inferior rectus recession, which I much less frequently do now. 75% of them were with that. And some of them also had a nasal transposition to try and prevent the A pattern XT, but again, that actually makes the intorsion worse. And 83% of the patients had that combination. Again, looking at A pattern with XT and down gaze, it's again fairly common in Graves' disease, the severe form. It was published by these various authors. In my SCOBY lecture in 2001, it was present in 19% of 135 severe thyroid eye disease patients and symptomatic in 13%. And it seemed to be worsened or caused by extraocular muscle surgery, as it was in this case. And the presence or risk of this A pattern complicates correction of intorsion by using rectus muscles, because all the standard procedures that we see here will make the A pattern worse if you're doing them to correct the intorsion, or if you're correcting the A pattern, they will make the intorsion worse. Now, the etiology is not clear of this problem. Some people thought it was a tight superior rectus, and sometimes it is. You can demonstrate that on scanning. Again, many times it was following orbital decompression, and it's felt that the globe repositioned inframedially and posteriorly induced extra tension on the superior oblique tendon because it's suspended anteriorly from the trochlea, and that would increase intorsion. And also the simultaneous recession of the medial rectus and the inferior rectus weakens two adductors and recruits the superior oblique and down gaze, which is going to give that A pattern XT and down gaze and more intorsion. I first presented this technique in the 2001 AAPOS meeting. Mike Kipp presented, one of our fellows. We presented 4 patients at that time, and since that we've accumulated 5 more patients. Although I have to say the presence of this condition is becoming less frequent. I haven't seen a patient since 2012. I think largely because of different orbital decompression techniques that we're using, and possibly also because of Tepezza. But I had 9 patients that we were able to accumulate from 1996 to 2012, and again, none since that. 7 were female, 2 were male. All had torsional diplopia from intorsion, all had significant A pattern, all had the typical bilateral orbital decompressions and medial rectus recessions, as well as bilateral inferior rectus recessions. 3 had intorsion prior to their strabismus surgery and 6 only after that. And this just summarizes the results of this procedure. The pre-op intorsion was significant in most patients, 8 to 32 degrees. And the post-op intorsion was much, much better with a mean of 5 degrees. Intorsion reduction also, it's a very powerful procedure, 8 to 26 degrees. And it seemed to be a bit self-adjusting. The patients who needed more correction got more correction. This procedure also, interestingly, improves the A pattern, XT and down gaze as well. And the follow-up in my series was 7 months on average. Now, 4 of the 9 patients needed additional surgery for intorsion. And those were ones that had intorsion of 20 to 32 degrees, so very large intorsion of presentation. One patient I had done in the early days, bilateral superior oblique silicone expanders, and that decreased the intorsion only from 26 to 20 degrees. and a very slight change in the A pattern. So this patient went on to have my AAIO procedure. 2 patients had bilateral superior oblique tenotomy early on, again, with slight improvements in intorsion, but nowhere near what was needed in either patient, again, as Garrity had found. And 1 patient, the one that was just presented previously, required reoperation for persistent intorsion even following the AAIO procedure. Her intorsion started at 4 degrees until she had her strabismus surgery, then increased to 25 degrees. And then, as you see here, decreased slightly with superior oblique tenotomy, but not much. And then a lot more with the AAIO procedure. And then with the resection added, and we got a nice result. 6 millimeter bilateral resection of the transposed inferior oblique was that additional procedure, which was very useful. And a follow-up on her was 25 months. So it's a very excellent long-term successful procedure. So in terms of our results, all patients were free of torsion and diplopia at the last visit. There were no vertical incompetences to torsion correction, which we were a little surprised about. The variance between up gaze and down gaze was only 0 to 4 degrees. And we would have suspected that the increased contraction of the inferior oblique and up gaze might have changed that, but it really didn't have much effect. 1 patient had an induced vertical and post-op torsion correction was very stable, with all patients varying no more than 1 to 2 degrees over the follow-up period. So in conclusion, torsional problems are not uncommon in Graves' eye disease. I think the problems do vary depending upon the techniques used to treat these patients. And so I think the problems that we're seeing now are somewhat different from the problems that we saw back in the 1990s and the 2000s. But shifting of rectus muscles to correct intorsion is complicated frequently by the A pattern XT and down gaze and vice versa. Superior oblique weakening is often ineffective. In my experience, it's almost never enough if the patients have more than 10 to 12 diopter degrees of intorsion. The AAIO procedure can correct intorsion and torsional diplopia, as well as help reduce the A pattern. And in my experience, has been effective in all the patients it's been used on. Resecting and advancing the transposed inferior oblique for large amounts of torsion can be done either as a second procedure, or now for the larger ones, I would actually do it as the primary procedure on adjustable suture. And again, it can be performed on adjustable suture. Again, I want to thank the program committee for inviting me and congratulate Bert on his long career. Thank you.
Thank you, Dr. Del Monte. We have a few minutes for to address any questions. Maybe we'll have the other panelists turn on their cameras and mics. Let's see.
Stop sharing.
I think we'll take the share off. I know some of the questions that have come through have been addressed already online, but I thought we maybe just take a couple of minutes. Dr. Del Monte, there was a question. Your patient looks so much better post-op. Do you think the inferior oblique procedures help the retraction, proptosis, etc., significantly, as well as the diplopia?
Yeah, good question. Yeah, definitely. She also had a final lid surgery. All of our patients start out with their orbital surgery. Originally, it was just for ischemic optic neuropathy. Now it's actually done for cosmetic purposes. And then they had their strabismus surgery, and then finally the lid position surgery was done last. And she did have that, which obviously aided her cosmetic appearance. But I think it did. It was remarkable that it was so successful at not only the intorsion, but also the correcting the A pattern without causing significant additional strabismus.
Dr. Kraft, I know you had addressed a question about upshoots and downshoots, but I wanted to follow up on that. Have you had an opportunity to resect a lateral and split it to help with an upshoot or downshoot? Anything like that's you've tried that?
No, I think, as I mentioned in the talk, if there's significant up and down shoots, I've shied away from any lateral rectus resections because depending on the mechanism, if it's a mechanical mechanism, you're going to make it worse. There are other types of upshoots, and I've actually described them a number of years ago, and others have as well, in which the complex co-innervation can also cause the superior rectus to be co-innervated with the medial and lateral on adduction. And in those cases, it's actually an innervational upshoot, which is a sort of a gradual rise instead of an abrupt rise, as they call it. And in those cases, you have to attack the superior rectus, in my opinion. So they're actually different categories of upshoots. And if they're significant, I have to look for others. As I discussed, you have to look for other strategies in the plan other than a resection of the lateral.
Thank you. It sounds like the topic of another Kushner webinar.
For sure.
Dr. McEwen, I was curious, have you had to go back and operate on one of these muscles when you've done the vessel sparing recession? And what did you discover with those vessels? What do they look like?
Well, I think I've only done it once, but it was very interesting. So early in our course of doing this, we had to go back and operate on a lateral rectus. So I was experimenting a little bit this many years ago, and preserved it on a lateral to see if the technique was feasible for a patient who really needed it. And then we had to reoperate. When I went back, it was patent, it was adherent to the sclera. You could not dissect it free again. Hopefully that's true in all of them. I suspect it's not, but this one it definitely was. And I used again our little peristaltic pump with the Stevens hook, and it filled very nicely. Only one case.
One case, that's great. Well, thank you. I know there'll be other questions coming up, and if the panelists have time, they may be able to address those in the through text and the chat. We're going to switch gears, and we're now, it's my honor to introduce our 7th Kushner lecturer, Dr. Stephen Archer, and we'll let him bring up his slides. There we go. Dr. Archer is the Ida Lucy Yacobucci Collegiate Professor of Ophthalmology and Visual Sciences at the University of Michigan, Kellogg Eye Center. Dr. Archer has been in the field for over 33 years and has published and spoken extensively on topics related to pediatric ophthalmology and strabismus. He has an uncanny ability to get to the heart of an issue and make us all question what we think we know about strabismus. So we're looking forward to Dr. Archer's lecture, which is entitled Superior Oblique Apocrypha. And we'll turn the time over to him.
Oops. Okay. Is my audio on?
Everything looks good.
Okay. Well, I'd just like to thank Bert for inviting me to give this lecture. It's a tremendous honor. Thanks, Scott, for organizing this. The title of my talk is Superior Oblique Apocrypha. I don't have any financial interests to disclose. So for those of you who are not familiar with the term, I'm going to try to get rid of some of my, all right, it's not easy to get rid of the pictures here. Let's go back. Oops. There we go. All right, so Apocrypha comes from the Greek word apokrypsos. I think I'm close on the pronunciation there, which basically means hidden. It's usually used to refer to some non-canonical biblical writings that originally were considered esoteric knowledge that was too profound or sacred for the uninitiated, which is why it wasn't included in the Bibles. Or subsequent meaning has been changed a little bit, and now it's regarded as writings of questionable value or dubious authenticity. So there is a certain amount of religious fervor involving some of the superior oblique concepts I'm going to talk about, but I'll let you decide which of these definitions apply to what I'm going to talk about. So this is a complicated story. It's got a lot of subplots that are going on at the same time. So I'm going to come to points at which you'll say, but what about, and so when we come to this, you're going to see this symbol, which means, yeah, I know, we'll get back to that. So all the data and cases in this have been depicted as left superior oblique palsy. So, we're very specialized, but I don't just operate on left superior oblique palsies. I'm very versatile. I also operate on right superior oblique palsies. I'm going to restrict this talk to strengthening procedures, mostly superior oblique tuck. I know people doubt that there's such a thing as strengthening procedures, but we'll come back to that again. In the literature, we're going to talk about things that are found there. A lot of this is going to be orbit simulations. I'll give you a few case reports, a few anecdotes, maybe some hearsay. And most of the data comes from a series of superior oblique palsies that were performed by Monty and myself over a 20-year period, that were collected and analyzed by some of our former fellows, Shavisa Bunyavi, Alex Miranda, Sean Gappy, and Grace Wong. So the first thing I'm going to talk about is why we even do superior oblique tucks. A lot of people are afraid to do them. It's not in the repertoire of a lot of pediatric ophthalmologists. And indeed, there are a lot of other ways of fixing hypertropia that don't involve a risk of Brown syndrome. So these are the typical patients that we operated on, these with a superior oblique tuck. This is aggregate data from 46 patients. You might ask why there's only 46 over that long period of time, but these are only unilaterals, and anybody with any kind of concomitant, concurrent cyclovertical procedure other than the superior oblique tuck was excluded. So that kind of severely limited what we had, and this is what's left. They all have this particular pattern, which we'll go over in a second here. And they all had presumed superior oblique palsy by the usual criteria, 3-step test, but whether they really are superior oblique palsies, we're going to circle back to. So these are the mean pre and post-op measurements for these patients. They had a hypertropia. The hypertropia is, the hypertropia has a lot of lateral incompetence, much worse on one side than the other. It's worse in down gaze, but it's worse in the field of action of the superior oblique. And they all have some extorsion. Now, we do superior oblique tucks on them, and this does a good job of reducing the hypertropia in primary position. The median of this is actually 0. And there wasn't a single overcorrection in this entire series. So the reason why this average is not 0 is because there are a few undercorrections that are average in there. Did a very good job of reducing the lateral incompetence. It gave more help in down gaze, and especially in the field of action of the muscle, and it reduced the extorsion. So all of these things are very important because a lot of these patients have more trouble in reading position because the deviation is worse in down gaze, and the extorsion tends to be worse in down gaze as well. So this is not a surgical technique talk, but just to show you the superior oblique tuck, you isolate the muscle, which is fairly straightforward. You put in the tendon tucker. The critical step is deciding how much to tuck. Put in a mattress suture to fix it in that position. And you're done. Test to see that you're happy with the amount of tuck that you've done. And that's all there is to it. Now, the most critical, the most critical step is deciding how much to tuck. And so the question is, why do so many pediatric ophthalmologists not do this procedure? Why is there so much fear of the superior oblique? And I think that's partly because most strabismus surgeons are used to going into this procedure wanting to know how many millimeters to do. Whenever my fellows call me and ask me what to do, I say, well, I'd operate on this muscle. And invariably they ask, well, how many millimeters? But in superior oblique tuck, the critical step is determining how much tuck by the feel of the muscle. For me, it's pretty easy. I tighten it up and I get it as tight as I can and still be able to pick up the tendon with the tucker easily to get the suture under it. So pretty straightforward, but many surgeons are not comfortable using a subjective determination for deciding how much to tuck. So Rick Saunders introduced this test many years ago, which I found very useful. And what he does is he pushes the eye up and in at the end of the case, or I should say in and up, I think is the sequence that he likes to do it in. And if you have the proper tension on the tuck, you should meet resistance just as the inferior limbus crosses the intercanthal line. Another test that I add to this is a test passive extorsion. It should still have about 15 degrees of extorsion before you hit the wall. If you've got the right amount of tuck. I think Irene Ludwig likes this passive extorsion for judging laxity of tendon as opposed to the Guyton exaggerated adduction test. So another method that has been advocated is to match the forced adduction to the normal eye. That makes sense for bilateral tucks. I'm not sure how it works for unilateral tucks because there really isn't any resistance on the Saunders test in a normal eye. So in an effort to make this a little less subjective, Rick Saunders in his Kostenbader lecture, and I'm going to be referring back to this important lecture a number of times, as well as a Kostenbader lecture given by Dave Plager a few years later. But Dr. Saunders devised this tendon tucker with a strain gauge incorporated into it, and he graciously sent me one of these to try out, and in fact it seems to work. I found that 100 grams of force is about the right tuck for most of the patients that I did. So this may help take some of the angst out of doing this procedure. The other thing that Dr. Saunders pointed out is that the superior oblique tuck is unique in that the surgical dose is determined almost exclusively on the basis of intraoperative findings. So this anomaly of surgical dosing provides a unique opportunity to look at the dose-response relationship. If you, anybody who knows me will remember, I have kind of an obsession about this, going back to a lecture I gave a few years ago. And this is kind of a typical dose response curve that you'll see with, this is Jim Mims data for esotropia, and you see you have the amount of recession and the amount of surgical effect that you get, and it describes a nice curve. But if you plot this a different way, if you look at the preoperative deviation and plot that against the surgical effect, you see that also gives you a nice line. And if you look at the correlation, the preoperative deviation actually correlates better with the response than the amount of surgery does. But it's hard to sort out because the amount of surgery is a strict function of the preoperative deviation. So you can't really separate these two factors very easily. But you see here that most of the results fall along this line here. I've put this little dashed blue line in here to represent the when the effect equals the amount of preoperative deviation. We'll call it the get what you need line. And you see that most of the patients fall in this get what you need line with a few undercorrections falling off the bottom here. A series by Scobie back in the 1950s gave us a unique opportunity to separate the amount of surgery from the preoperative deviation as factors for the surgical response. He just did uniform 6 millimeter recessions on each muscle, and so the amount of surgery really isn't a variable. And if you plot the preoperative esotropia against the surgical effect, again you get most of the patients fall on the get what you need line, with a few patients falling off the bottom. Well, superior oblique tuck is another situation that gives us this unique opportunity where the preoperative hypertropia is not at all related to the amount of tuck that was done, as you can see in this scattergram. And as you would expect, the amount of tuck is also not related to the amount of hypertropia correction that we get out of the superior oblique tuck. But if you plot the preoperative hypertropia against the amount of hypertropia correction you get, once again, you get most of the patients falling on the get what you need line and a few undercorrections falling off the bottom. It's just amazing how many strabismus procedures that give this same graph. Just kind of a little spooky. The next thing I want to talk about is lax tendons and congenital superior oblique palsy. So just a little bit of history on the superior oblique. The superior oblique well, the extraocular muscle arrangement is highly conserved in vertebrates. It's really unchanged since the very first vertebrates 530 million years ago, which has 4 rectus muscles and 2 oblique muscles. Originally, these oblique muscles are almost exclusively torsional, which was much more important to laterally facing animals that move in 3 dimensions, like fish who go up and down and need some torsion to keep their eyes level. The 2 main things that occurred over time is that the eyes migrated in some animals from a lateral position to a more frontal position, which conflated the torsional and vertical movements of the eyes. But also with the advent of mammals, a couple of 100 million years ago, we got the only major change in the muscle plant in the entire history of vertebrates, and that is that the origin of the superior oblique moved back to the near the apex of the orbit, and the trochlea appeared more or less in the position that the superior oblique was originally attached to the medial wall of the orbit. And as Darwin said, in those cases in which the modification has been comparatively recent and extraordinarily great, we ought to find the generative variability, as it might be called, still present to a high degree. And indeed, the superior oblique has the most variable insertion, although the inferior oblique is not far behind from a classic paper by Fink in 1947. The superior oblique is the most frequently absent muscle, and the superior oblique has the most frequent tendon anomalies, which were classified by Helveston and colleagues. And we're going to concentrate mostly on type 1 anomaly, which is the lax tendon. So in Helveston's Bilshowski lecture, he, I guess because he grew up in the Detroit area, made this analogy to a car. The muscle belly is the engine, the tendon is the drive shaft, and the trochlea he described as the transmission, which and eventually various interesting properties were ascribed to that, and we'll try to go over that. But most of those were allegedly due to the telescoping of the tendon through the trochlea, which he described in what was really the first anatomical study of the trochlea. Plager went on to claim that the traction test is mainly evaluating the tendon laxity between the trochlea and the globe, and the atrophy of the proximal skeletal fibers probably would not be transmitted to the distal trochlea, which is relatively fixed to the telescoping tendon. Now, I'm not sure I exactly understand how the trochlea isolates these 2 things to one side or the other, but we're going to talk about that a little bit here. As the eye moves up and down, the insertion of the superior oblique moves forward and back on the eye, as described here. I don't think it's quite 8 millimeters. This was an anatomical calculation that was made, but we'll talk about that a little later. But if the central fibers of this tendon move further, almost twice as far as the peripheral fibers, I don't think anybody is claiming that these fibers do anything other than pass from the muscle all the way through the trochlea to insert on the sclera. There's nothing that inserts in the trochlea. There's nothing that originates in the trochlea. They all pass right through. So if there's this differential movement, that has to be reflected at the insertion end somehow. So in trying to think about how that might possibly occur, it is possible that when you're in down gaze and the central fibers are more retracted, that the insertion bows towards the trochlea, and in up gaze where they travel further forward, the insertion is bowed further back. Now we all know that the insertion floats around a little bit on the sclera as we do strabismus surgery, but this is a long way for adjacent pieces of sclera to migrate in opposite direction. And of course, after a tuck, none of this is in play because it fixes all of the tendon fibers at relatively the same length. The other alternative that I think could be considered is that in down gaze, it may be that these central fibers that move further pull the insertion closer to the trochlea, but the peripheral fibers that don't move as much are just flaccid afterwards, after this movement. And then similarly, if we go into upgaze, the fibers that really restrict the amount of movement here are the peripheral fibers, which don't relax as much as the central fibers do. I'll let you ponder the plausibility of these two systems, but let's go on to look at what the implications allegedly are. And that is that loose tendons are found in congenital palsies, which in fact may be normally innervated according to Dr. Plager. And this makes theoretical sense to treat an anatomical problem with a mechanical solution. And he goes on to say that tucking may only be the procedure of choice in markedly lax tendons. And we're going to come back to that one too in a moment here. But let's talk about the normally innervated part first. So MRI studies at the superior oblique clearly show that there is a smaller belly of muscle in congenital versus acquired palsies. The smallest bellies occur in patients with lax tendons. So I'm not sure how to interpret this. This may mean that the palsies are just more severe in congenital cases, which may be why there's more atrophy and more laxity of the tendon. Or it may be that this is not atrophy at all, that this is actually hypoplasia of the superior oblique belly that is just part of a global dysplasia of the entire superior oblique muscle complex. But either way, the muscle belly is certainly not normal in these patients. All right. So yeah, there we go. Have a little lag on the transitions here. So the Guyton exaggerated force duction test, which I've sort of illustrated here to kind of help me understand how you feel that tendon flip over the top surface of the globe, is the standard method for determining whether a tendon is lax or not. But that again is a subjective, not a quantitative measure. But Rick Saunders again pointed out that laxity is measured directly by the amount of tuck when you grade the tuck based on tendon tension. And he found in his series that the congenital superior oblique palsy patients received on average 3 millimeters more tuck than the acquired superior oblique palsies did. But there was a wide variation, and at least one known traumatic received a tuck as large as 12 millimeters. So he didn't feel that this necessarily supported that tendon laxity per se is ever the primary disorder in congenital superior oblique palsy. In our series, we had similar findings, except more exaggerated. There was a 5 millimeter difference between the congenital and acquired patients. But if you plot the amount of tuck versus the proportion of acquired and congenital palsies that get that amount of tuck, you see that yes, the acquireds have mostly more of the smaller tucks, the congenitals have more of the larger tucks, but it's a smooth transition in between with about equal numbers of patients getting 7.5 millimeter tucks. So the fact that there's no sharp transition suggests to me that this is a quantitative difference between these groups and not necessarily a qualitative difference. And again, looking at some of the other data on these patients, again, there's a 5 millimeter difference in the amount of tuck, but every other parameter, the amount of preoperative hypertrophy, the amount of preoperative torsion, the amount of correction of both hypertrophy and torsion that you get from a superior oblique tuck is indistinguishable in these two groups, again suggesting that there's really not anything qualitatively different about these two groups of patients. Now, the next thing I want to address is whether there's such a thing as a strengthening procedure. A lot of people believe that resections, and by analogy a tuck, really doesn't change the contractile properties of the muscle. It really just affects its passive properties, restriction and elastic properties of the muscle. So we looked at that in our patients, and this graph requires a little explanation. Each bar represents a patient, and the top of the bar is the amount of correction that patient got from a superior oblique tuck in primary position or in the field of action of the muscle. And so it kind of flips around. So on the red ones, where we had more correction in primary position than in the field of action of the muscle, the primary position is on top and the field of action is on the bottom. We had one patient who had equal correction in primary position and field of action, but in patients who had more correction in the field of action of the superior oblique muscle, that's down and in, that number is on top, and the amount of correction achieved in primary position is on the bottom. And you can see that most of our patients had more correction in the field of action than they did in primary position. And some of them on this end, for example, had a lot more correction in field of action than in primary position. And I don't see any way that you can explain getting more effect in the field of action of the muscle from passive effects. So I conclude that this must be due to increased active muscle force in its field of action. Or another possibility is that we're also correcting torsion with this. So could the altered rectus muscle paths that occurred because of the correction of torsion actually explain why the deviation is so much better in the field of action of the superior oblique muscle? We're going to circle back to that, but give you a spoiler alert, probably not. The next question I want to talk about is lax tendons and superior oblique tuck. Now, should we only do superior oblique tuck in patients who have a lax tendon? Come on, very slow transitions here, but this is the first tiny tuck that I ever did. This was probably 25 years ago. This was an 18-year-old woman who came in. She had just started college. She'd known she'd had some sort of problem for a long time, but she was really starting to have a lot of trouble with the increased studying that she had to do in college. Now she was a Michigan State student, so I'm surprised studying was an issue. But at any rate, she had a tiny deviation in primary position, just a whopping deviation in contralateral gaze. But the big issue was that she had a big intermittent hypertropia in reading position. And she could fuse this, but it was a lot of work and it was getting harder and harder for her. So I looked at this and I said, well, she's fusing a big hyper. This is probably a congenital superior oblique problem. I'll plan to tuck the tendon. And I got in there and her tendon was not at all lax. And I said, well, I can go to plan B, or I can just go ahead and tuck the tendon anyway. So I did go ahead and tuck the tendon. I like this notation. The number that you read off the tendon tucker is half of the amount that you're actually tucking. So when you say, I did a 3 millimeter tuck or a 6 millimeter tuck on an op note, it's hard to know what was done. But I like this notation because it's unambiguous. So this was 2 millimeters on the tucker for a total of 4 millimeters of tucking. And post-operatively, she had a little tiny Brown syndrome, but it fixed her hyper. Most importantly, it fixed this huge deviation in contralateral gaze, and it reduced her her reading position deviation to just a flick of left hyperphoria, and she was fixed. So these are bookends. That was my first tiny tuck. This is my last tiny tuck, which I saw at post-op just a month or two ago. And she had a little less of an extreme pattern. I think this is probably an acquired deviation. She got a total 4 millimeter tuck as well. And here's what happened with her. Nice correction of the deviation in primary position. She's had a little bit of residual deviation in the field of action of the muscle, a minimal Brown syndrome. She doesn't notice any of this. She's sure she has no double vision anywhere. So we looked at a series of these tucks. Here's 27 of them that were tiny in the range of 2 to 6 millimeters total. This is what we found. This is, again, the aggregate data on these patients. And they had on average about 9 millimeters or 9 prism diopters of hypertropia, and post-operatively it was reduced to pretty close to 0. They had much larger deviations in the field of action of the superior oblique palsy, again greatly reduced by these tiny superior oblique tucks. Down gaze, again, a little greater in down gaze, initially nicely corrected by the superior oblique tuck, and the lateral incompetence was almost eliminated by these tiny superior oblique tucks. So basically, the superior oblique tuck checks all of the same boxes that for this pattern of deviation. as a tuck, regular tuck does in patients who got larger tucks. So most importantly, none of these patients required any intervention for postoperative Brown syndrome. Basically superior oblique, I think, is equally effective for patients who have this particular pattern of hyperdeviation, whether the tendon is lax or not. Now, the next thing I'm going to address is a question of whether these are really superior oblique palsy patients. Joe Deemer and Bob Clark have published just a huge volume of information on pulley anomalies, and they found that many patients with a three-step test consistent with superior oblique palsy do not have superior oblique atrophy on MRI. Now, I'm not entirely sure that this rules out superior oblique palsy, but it makes it a little suspicious. But then they subsequently found that in some of these patients who looked like superior oblique palsy, they actually had anomaly or heterotropia of the pulley positions for the medial rectus, superior rectus, and inferior rectus. And they did simulations which show that just the pulley heterotopia can produce a similar pattern to the superior oblique palsy that we've been talking about. I did my own simulation with the mean displacement of heterotopia of the pulleys that Deemer and Clark described, and it does give kind of a pattern that looks like a superior oblique palsy. I must have done it wrong though, because I didn't get as much deviation as they did. I could only get about 2 prism diopters of left hypertrophy out of this and about 1/2 degree of extorsion out of this. There we go. But nonetheless, I'm not going to discount that. I don't have a large NIH grant to perform preoperative MRIs on all of my patients. So telling you whether or not any of these patients actually had pulley heterotopia instead of superior oblique palsy is sort of above my pay scale. So perhaps the terminology police would like me to describe these as head tilt dependent hypertropia worsened contralateral gaze with extorsion, as these terminology people tend to come up with brief descriptive paragraphs instead of a terminology. But that doesn't really roll off the tongue, and I want to finish this talk before the end of the day. So this also doesn't lend itself to any kind of acronym that might be cute. So for the purpose of this talk, I'm just going to refer to these as superior oblique palsy. Now, I acknowledge that some of these may be pulley heterotopia, especially in the acquired adult patients, but that is what it is. But if you, boy, this is really, okay, but if you look at the data, there really isn't any bimodal distribution of either the clinical features. Oh, yeah, it's kind of random. There really isn't any oops. Yeah, I'm really having trouble with the advancement here. There we go. All right, well, let's talk about lateral rectus resections, for example. They produce a characteristic response that we exploit for a variety of conditions, not just sixth nerve paresis. So I don't know that there's any reason to believe that the characteristic response from a superior oblique tuck would only apply to cases of true superior oblique palsy. And if you look at our data, there is no bimodal distribution. The clinical features of if there are patients with pulley heterotopia, their clinical features are indistinguishable in our data, and the surgical response to a superior oblique tuck is indistinguishable. So if the superior oblique tuck produces the same results, whether it's a superior oblique palsy or not, to quote someone famous, what difference at this point does it make? So the next thing I want to address is how effective superior oblique tuck is for correcting extorsion. And again, we see that the amount of tuck doesn't correlate very well with the amount of extorsion correction that we get. But what you do see here is that it tops out at about 10 degrees of extorsion correction. And if you do my usual plot of the preoperative extorsion versus how much extorsion correction, it's kind of a similar pattern. Oops, kind of a similar pattern. You get the points falling more or less on the get what you need line, but it's not as good a correlation as some of the others that we've looked at. Now, we're going to look at some of the unique properties of superior oblique superior oblique tendon. I want to kind of point out some of the things. Now, we all know that the superior oblique, the vectors that are produced by the superior oblique muscle are a little bit of abduction, some vertical, and a little more torsion. These are the percentages of the vector that are going into each of these axes with this muscle. But the unique thing about this muscle is that fibers at different sides of the muscle have very different effects. So the fibers that are on the posterior pole or posterior portion of the muscle have almost equal vertical and torsional effects, whereas if you look at the fibers at the anterior portion of the tendon, they're much more weighted towards producing torsional effect. So we can use that in patients where we need to correct more than 10 degrees of extorsion, or if we don't really want to correct any vertical, we really just want to correct the extorsion by the Hirata-Ito procedure. I've got the Fels modification illustrated here, where we actually move the tendon to a new location. And this sort of makes sense because we're taking fibers who have mostly a torsional effect, and we're moving them to a position where they're tighter, but still have almost exactly the same torsional effect. The vertical effect is reduced, but the muscle is tighter, the fibers are tighter, so the net is pretty much zero as far as the torsion is concerned. It's very useful to judge how much torsion you're getting by putting some markings on the eye. Some people have advocated using fundus torsion intraoperatively to decide how much to tighten the superior oblique tendon. I find these dots to be useful. I started using silk sutures at the limbus for this purpose back in the 1980s. When I came to Michigan, Monty taught me that it was easier to put on these crescent violet dots on the eye. And one of our former fellows, Jonathan Holmes, has since popularized this for gauging transpositions, and also I've seen a paper where he's used it for bilateral advancements. And okay, so the next question that I want to address is extorsion and hypertropia. And the question is, does the hypertropia actually is the hypertropia actually due to the extorsion, or could we improve the hypertropia by correcting the extorsion? Now, I first became aware of the relationship between extorsion and the vectors of the rectus muscles in a paper by Bert Kushner back in the mid-80s. And it kind of blew my mind. I had never really considered that the vectors of the rectus muscles will change significantly in the face of extorsion. And so that just opened up a whole new area of consideration for me. So in a superior oblique palsy patient, if they have extorsion, here's illustrates what happens with about 10 degrees of extorsion. The inferior rectus will be shifted nasally, the superior rectus will be shifted temporally, and that will change their vector balance. For primary position, the horizontal muscles are kind of a wash. One goes up, one goes down, they balance out. But for the field of action of the superior oblique, down and in, that upward displacement of the medial rectus may be important as well. So the question is, could correction of the torsion explain some of the effect of the surgery of a superior oblique tuck on the hypertropia? Well, if that's true, you would expect some relationship between the amount of extorsion. You know, if the hypertrophy is caused by the extorsion, there should be a relationship between the amount of extorsion and the amount of hypertropia. And preoperatively, there is a correlation, and that's kind of what you would expect. If they're both caused by superior oblique palsy, you would expect the more severe ones to have more extorsion as well as more hypertropia. But the relationship is not really as strong as I would expect. So I looked at this experimentally, or theoretically, and you see that with extorsion, the inferior rectus will be displaced in a way that actually increases the proportion of its vector to depression. And for the superior rectus, the extorsion will shift its vector to make it a less effective elevator. So I've done a bunch of extensive analysis. I'm just going to show you one slide because we've got limited time here. But if you look at the changes in the vector forces that occur with the torsion, and you add them up and you look what effect that should have on the verticals, the change in the rectus muscle vector should actually produce a left hypotropia in a small amount. But there's a lot of other things going on, as we said, affecting the correcting 10 degrees of extorsion would, as far as the vectors go for the inferior and superior rectus, should produce more hypertropia, but the path length of those muscles is a little bit different, and that is altered by about 1 millimeter in a way that would favor less hypertropia. On balance, it's a wash in just about all situations. The other thing is that shift in the medial rectus position in the field of superior oblique action. And then what about the pulleys? Well, in Clark and Deemer's paper, where they looked at this, they found that ocular torsion did not correlate with the amount of pulley displacement, so they did not think that it could account for the pulley displacement. The flip side of this is that changing the torsion may not alter the pulley displacement. At any rate, I run this analysis with the inferior and superior rectus vector changes, the path length changes, with and without the medial rectus displacement in the field of action of the superior oblique, with and without the mean pulley displacements reported by Deemer, and with and without normalization of the pulley displacement with torsion correction. And the bottom line is that theoretically, the net effect of correcting the 10 degrees of extorsion is minimal in primary position, in down gaze, and in the field of action of the superior oblique. So I don't think these data really support the idea that this is due to the changes are due to changes in torsion. But what about the actual data? Well, I don't do a lot of isolated Hirata-Ito procedures without any other cyclovertical procedure, but here's a handful of them. And so you would think that if the hypertropia was due to the extorsion, we could just do superior oblique or do Hirata-Ito procedures on everybody and never have to bother with a tuck. Well, this is what we see happens with the hypertropia with these isolated Hirata-Ito procedures, and it's kind of random. The ones with the most correction of torsion from the superior oblique tuck, one of them had all of their small amount of hypertropia corrected. One of them actually got worse by 2 prism diopters. So not a lot to go on there. But these are patients with small hypertropia, so they may not count. But let's look at the superior oblique tuck data. So again, you would think that the ones that had more extorsion correction would have more hypertropia correction, but again, there's no correlation there at all. In the field of action of the superior oblique muscle, again, the ones with more superior oblique correction didn't particularly have more correction of the hypertropia in the field of action of the muscle. So probably not a big factor. The last thing I want to talk about are some unusual procedures, exotic procedures that I didn't have any place else to put, but I want to look at them through the rationale of what the vector forces are on different parts of the superior oblique tendon to try to understand them. So the first one I'm going to talk about is the anterior tuck that was described by Pinellas and Velez. This is done in situations where you would do a Hirata-Ito procedure, and they feel that this is an easier procedure to do than the Hirata-Ito procedure. And it kind of makes sense because you are tightening the fibers that are more engaged in torsion and keeping their same vector path. So it's just strengthening those anterior fibers. I've done a few of these. I've found that they do work. I probably would like it better if I had grown up doing them, but I have a much better feel for what to do with a Fels procedure just because I have, or the Fels variation of the Hirata-Ito, just because I've done so many more of them. And plus, if I look at those dots and find that I did the wrong amount, I find it much easier to modify that with the Hirata-Ito procedure than I do with this tuck. But it does work and it does make sense. Now, the next thing I'm going to talk about are, I don't know if anybody remembers Letterman, but stupid superior oblique tricks here. So one thing that, and I've made this same mistake, I believe this once before I had actually thought about it, is the Hirata-Ito plus. So if you have a patient who has mostly torsional problems, but a little bit of hypertropia that you'd like to correct, the temptation is, instead of just moving these anterior fibers, which are mostly concerned with torsion, to the Fells point over here, where the amount of torsion is still about the same, you can take a little more of the tendon, include some of these fibers that are more involved with vertical, and move them to the same point, and maybe get a little vertical correction out of this as well. Well, this doesn't make any sense, because the function of those fibers is not a function of who they are, where they came from. It's a question of where you attach them. So actually what you're doing when you do this is you take fibers that were well positioned to have a vertical effect, and you're removing most of that vertical effect and converting them more into just extorters. So this procedure doesn't make any sense to me. Here you go, you have larger vertical vector, you're trading it for a smaller vertical vector on those extra fibers that you're transposing. However, there are some patients who seem to have a disproportionate amount of torsion to the amount of hypertrophy they are shown here. So these patients just have smallish vertical deviations, but a lot of torsion that we don't really expect to get if we were to just do a tuck. So what do you do with these patients? Well, the procedure that I like for this, and I think other people have probably done this, but I haven't seen it described anywhere, is I tuck the posterior portion of the tendon for the vertical deviation, and I do a Hirata Ito for the anterior portion of the tendon for the torsion. And the next procedure I want to talk about is superior oblique advancement, which has gained some popularity. So we know that the superior oblique has this distribution of effects, more torsional than vertical in its normal position. But if you took that tendon and advanced it along the same line, you would just strengthen all of these vectors in the same proportion. But you really can't do that, because if you straighten it along the same line, you would be tacking it down back by the macula here, which is perhaps doable, but not something that anybody really wants to do. So the tendon really gets advanced to a place kind of over in this area. And the problem with that is that you're taking a muscle that has a modest vertical effect, and you're kind of giving up half of that vertical effect. So that doesn't make any sense to me. Now, Archer's law of strabismus is, just because it doesn't make sense doesn't mean it won't work. In fact, if you take a vector and you move it to a less favorable direction, so that less of it is contributing to the vertical vector, you can make up for that by strengthening that vector enough to equalize that. But I'm not sure why you would ever want to take 2 steps forward and 1 step back by moving that tendon to that position. Now, the last situation that I want to talk about is another questionable practice. I'll give you a case history. This is a 38-year-old woman who crashed a bicycle. She hit her head, saw stars, and now she has double vision. She has a history of a scleral buckle 16 years ago, diagnosed with a superior oblique palsy. Minimal improvement over 6 months, was doing okay in primary position with a Fresnel prism, but she's a geology postdoc, and I guess using a microscope is something that she has to do. So she's having a lot of trouble with reading, but especially using a microscope. And if my slide will change, the reason for that is that while she has an incombinant left hypertropia that fits the pattern that we talked about for patients that like superior oblique tucks, she does okay in primary position with prism, but she has more deviation in reading gaze. But more important, she has more extorsion in reading gaze. So even if you give her a different set of prism to use in reading gaze, which would be difficult to use with a microscope, she still has too much extorsion to fuse very well. So I went in to do a superior oblique tuck, because it kind of matches that pattern. And I went to look for it, and that superior oblique had become one with the scar ball that encased the buckle that she had years ago. I couldn't find any distinct superior oblique temporally anywhere. So I went nasally, and I performed a 4.5 total 9 millimeter tuck on the nasal portion of the superior rectus tendon. And in fact, that gave me pretty much what we wanted: fixed her deviation in primary position, fixed her deviation in reading position. Didn't have as great an effect on extortion as I might have hoped, but it reduced it enough that she could now fuse with that in reading position. And she's been followed for many, many years for her here at the university for her retinal problems, and continues to do well as far as her diplopia problems are concerned. Now, just a little note on on the nasal approach of the superior oblique. A lot of people are not familiar with this, but it's pretty simple. You just make a supranasal incision, pull the eye down with a hook under the superior rectus, reach under there with the Stevens hook, turn the tip up towards the underside of the Tenon's capsule and slide it forward, and out comes the superior oblique. And then one additional step that I like to do anytime I'm going after a superior oblique in a location that I'm not accustomed to is I like to verify that it's the superior oblique. I think other people do this, but just to make sure everybody's on the same page is you stick your finger on the trochlea and you pull on the tendon and you feel the cord going up into the trochlea. You know that's the superior oblique. There's nothing else in the orbit that does that. Just kind of a pro tip for that is that you can actually use this to confirm the diagnosis of Brown syndrome in some cooperative adult patients. You just stick your finger on their trochlea, have them look up and in, and you can feel the tendon if they've got a Brown syndrome. So some advise against performing superior oblique tuck nasally because of the fear of increasing the likelihood of a severe Brown syndrome, but I don't think this even makes sense. If you think about it, when you look up and in, the place where you would do the tuck is actually further away from the trochlea than it is in primary position. So Brown syndrome really isn't a problem with this, other than the usual caveats about how much you tuck in any other location. But if you look at the travel through this, again, this is from Helveston, a couple of Helveston's papers. He claims 8 millimeters of movement in both directions. That was assuming 50 degrees of adduction and 40 degrees of introduction and superduction in that position. It doesn't really amount to that much in real life. This is what the range of motion normally is. It's usually about 30 degrees of elevation, which is lower than any of the other directions for a normal human being. Adduction is about 40 degrees or 45 degrees. For people my age, it's probably more like 25 degrees of elevation and 30 degrees of adduction, or 40 degrees of adduction. So if we look at these numbers, what happens to the amount of travel that these muscles go through. If you look at the superior oblique, it shortens by about 5 millimeters and it elongates by about 6.3 millimeters under normal circumstances. So the place that you might actually run into trouble with the nasal tuck is in the field of action of the muscle. What would happen there is not a Brown syndrome, but you might limit the effectiveness of the procedure by running into the trochlea as the tendon tries to help pull the eye down. But as you can see, if you don't go stray too far from the nasal border of the superior rectus, there still should be plenty of room to get in a tuck there. So to summarize, I've recounted a lot of interconnected superior oblique myths and legends. And I'm going to leave it to you to decide how much of what I've told you is apocryphal.
Thank you, Dr. Archer. That was great. Really appreciate your time and wisdom. I'm going to now invite Dr. Kushner. And I know he has a few words to say. I know there's a few people that put questions in. We'll see if there's a chance for us to address those after the webinar via email or some other option. So appreciate those that have done that and paid attention. Dr. Kushner is on.
Well, first I want to welcome everybody. And Steve, I really want to congratulate you on an absolutely fabulous job. I think every time I hear you speak, I learn something. It gets me thinking, and many, many instances in this wonderful presentation. So you are following in the footsteps of 6 great predecessors, many of whom I see have logged into this webinar, including Steve Kraft, who was, of course, on the panel. I also want to compliment all of the panelists for wonderful presentations. Steve, you will shortly be getting the honorarium that accompanies this lectureship. And I will be presenting you very shortly. Let me just get my screen share up with the medal. As seen here, on one side is what is supposed to be a likeness of me, I'm not sure. And on the other side is the seal or logo of the great University of Wisconsin. So Steve, I have the medal here, and I want to see if I can reach all the way from Madison, Wisconsin to Ann Arbor and present it to you. And in doing so, I want you to know that no one that has received this medal thus far has contracted COVID while wearing it. So it's highly protective.
Well, thank you. 100% effective. It came through just fine. Here it is. I'll wear it proudly to prevent COVID. I just want to say thank you for inviting me and for hosting this. As so many people here have said, actually a lot of the concepts in this talk originated with things that you had talked about or written about that got me thinking, especially about torsion and its relationship. So, you know, again, this is really building on a foundation of things that you have presented over the years. So thanks again for inviting me for this tremendous honor.
Well, thank you again.
And I'd like to thank all those who attended, all the AAPOS members and guests, and to remind you that there will be a recording of this webinar available on apos.org, and there's a link in the chat, but if you go and look for meetings and webinars, you'll find that. And we hope to see everyone in Scottsdale, Arizona for our annual meeting in March 23rd to 27th. We hope everyone has a wonderful weekend, and thank you for all your time. At this point, we will sign off. Thank you, everyone.